All right, everyone. Good morning and welcome. Thank you for choosing to share this hour with us today. I know the morning is still early for a lot of us. My name is Christel. I'm an advisor with IDF Europe and also a diabetes advocate, consultant and public speaker, and I'm happy to be here today. Today's event, apart from being interesting, is also very personal to me. I live with type 1 diabetes myself. I had a grandfather who passed away from type 2 diabetes and a mother who lives with CVD. So I'm very honored to be here today to moderate this webinar. A unique webinar in many ways, a unique event that brings together both the diabetes and the heart communities, two communities that share a lot. The MEPs Mobilising for Diabetes and the MEP Heart Group have decided to join forces to improve not only quality of life, but really the future of millions of people living with chronic conditions. And today, more than ever, co-creation, collaboration, and synergies and mutual respect are very much needed to build resilient healthcare systems and to build a better and fairer and more sustainable future for all EU citizens. And I want to start off by thanking MEP Christel Schaldemose and MEP Sirpa Pietikäinen, the two co-chairs of the MEPs Mobilising for Diabetes, who are hosting this event today. And also, of course, thank the MEP Heart Group for officially supporting the webinar. So to open this event, I'm going to hand over to Christel Schaldemose. She's the co-chair, like I said, of MMD, the MEPs Mobilising for Diabetes. And for the past 16 years, since 2006, Ms. Schaldemose has been a Danish member of the European Parliament, representing the group of the Progressive Alliance of Socialists and Democrats. And at the Parliament, she's a member of the Committee on the Internal Market and Consumer Protection, the Special Committee on Artificial Intelligence and Digital Age, and also a substitute in the Committee on the Environment, Public Health and Food Safety. She's a busy lady. And in addition to being co-chair of the Diabetes Interest Group, she's also a member of the MEP Heart Group. And Ms. Schaldemose will provide us with some remarks to formally open this event. So please, Christel.
Thank you very much, and welcome to all of you to this morning event. I have been looking very much forward to it. I've been working with diabetes in the European Parliament for many, many years, but it is the first time that we have an event where we gather people also who is working with heart diseases. And in my opinion, that really makes sense. We need to we need to first and foremost avoid having a beauty contest amongst diseases, but we need to work together. Heart diseases and diabetes are linked, at least when it comes to risk factors. So there is a basis where we can work together and still allow us to have disease specific working as well. And that is what I hope we can do today, that we can find good ideas for the roadmap for the future. 10 years ago, more or less exactly, we adopted a resolution in the European Parliament on diabetes, and we are soon going to make a new one marking the 10 years kind of anniversary, but also marking the fact that EU is going to work more directly with health. We call it Healthier Together, an EU NCD Initiative, and I think that's very important. And I think that our two groups, the MMD and the Heart Group in the European Parliament, can help working with this. And when I looked through the resolution we made 10 years ago, I'm kind of, I think that we still have a lot of things to do and to tackle. The numbers, the figures are kind of the same still. I think that we have an awareness that is higher. I think that the member states know that this is something they really need to tackle to give better life quality for patients, to prevent better, and also to treat better. And if not because of the need of the patients, then also because of the need of the financial reasons for the member states. So we need to do a lot of things. Today is marking is one of the first meetings where we discuss together on diabetes and cardiovascular diseases. And I hope that this will not be the last one. But I'm looking forward to listen to the experts and the ideas. And together with Sirpa Pietikäinen, I can promise you that we will work very hard in the Parliament to make sure that we will see many of your good ideas reflected also in the resolution. The resolution can be used to put pressure on the EU Commission and the member states to do more. And we need to do more. For the patients with diabetes and cardiovascular diseases, they really need improvements in their everyday life. So welcome to this morning debate, and I'm looking forward to listen to all the good ideas. Thank you.
Thank you so much, Christel. You can tell I'm Scandinavian, but in fact, I'm calling Christel by her first name. I hope you don't mind. Apologies, Ms. Schaldemose. Now, it's my pleasure to welcome Mr. Artur Furtado to the virtual stage. Mr. Furtado is Deputy Head of Unit on Health Promotion, Disease Prevention, and Financial Instruments at DG Santé at the European Commission. Mr. Furtado played a central role in shaping the new vision for disease-specific roadmaps in the framework of the EU Non-Communicable Disease Initiative, Healthier Together, which Christel mentioned. Ms. Schaldemose mentioned, apologies. And the initiative was launched last year in December. And Mr. Furtado, you will speak about the current status and the way forward for Healthier Together. So please, the stage is yours.
Thank you very much for the kind introduction and for the Parliament and IDF to be organizing this meeting. I was already noting here for myself at least 3 points where we seem to be completely aligned. The fact that you are discussing cardiovascular disease and diabetes together, the fact that we have this vision that we should not be making a competition between diseases, and the fact that we should all do more and work together so that we have a friendly competition, but on how to make things happen on the ground. I think this is already a very good start. If you don't mind, I will share my screen just to allow you to have a view of the presentation. I hope it is now visible to you. If you could just confirm that that is the case.
We can see your screen, but there's something blocking it in the middle. It looks like the chat, I think, from Zoom.
It's better now, I hope.
Perfect, perfect.
Okay. So indeed, as you have kindly mentioned, we have been working on the Healthier Together EU Initiative for Non-Communicable Diseases since December last year. This has been a very interesting process in itself, and I will try to mention the reasons why. But the first thing that I would like to tell you, I know I don't have to convince you of this, but we have from time to time to highlight these points, is that really this is very important work to be done. The European Commission, the European institutions have a somewhat limited remit to work with the member states in the area of health, as you know. But even if we are able to make it just a small difference in the area of non-communicable diseases, this will amount to a lot to the patients and to the health systems, because non-communicable diseases represent roughly 80% of the disease burden, both in terms of financial investment of our countries, but also of human suffering. So there's really a lot to be done here, and this is an area that we should target. As you know, the Commission has launched the European Cancer Plan. This addresses in a very important way one important disease burden source, but we were missing from some time the work on the other communicable diseases in an ambitious way. This has only been made more urgent by COVID. It has shown very clearly how important it is to have a resilient workforce, a resilient population, so that we can face better health threats. And it has also shown that we will have most likely a worse period now in the near future because of all the backlog of problems that we have accumulated while our systems were completely focused on COVID. So this is very topical and very timely that we work in this area. We also know the tools that we should be using. They are not only prevention, but they should start for sure with prevention. And we also know that there is a wide agreement from all stakeholders that this should be the way ahead. It's part of our wish to build back better and to use the opportunity of the reinforced budget of the European Commission's health program. We call it EU for Health. So it's really our duty and our responsibility to be proactive in this area. This is why we've launched this initiative. It has a very simple, deceptively simple objective to increase our support so that the member states can implement policies, can make more ambitious action in the area of non-communicable diseases to try to reduce the burden, targeting their needs in a flexible way as long as they are fighting health inequality. So I'm sure this is something that we can all agree on. For those of you that are already familiar with the European Cancer Plan, it will not escape you that we have used the same type of building blocks. We are working with the member states so that more action can be done all the way in the spectrum from knowledge, better knowledge and data to quality of life of patients. Because we know where traditionally the underinvestment is, we are trying to step up as much as possible promotion and prevention, and something very relevant for diabetes and cardiovascular diseases, screening and early detection. The strands, you've probably heard of them. We are trying to cover, alongside the work on cancer, the main sources of morbidity and mortality in the European Union. So it will not surprise you that cardiovascular and diabetes are there, ranking first, unfortunately, but also respiratory diseases, chronic respiratory diseases, and mental health and neurological disorders. And also important to mention, we are doing this with the colleagues from the European Cancer Plan. We have an horizontal strand that will address health determinants, common risk factors that are behind most of the issues that we have with non-communicable diseases. And also, it will not escape you that lifestyle will be one of our most important areas of work, our suggestions of work for the member states, because it is behind many of the problems that we see today. We would like to see that the member states use this opportunity, and I'll tell you why and how in a second. For instance, to revise medical guidelines together, to initiate policy reforms, or something that we have been experimenting with a lot of success in recent years, that they identify and replicate at a wider scale best practices that can be helpful in whichever area of work they choose. What does it consist in practice, this EU NCD initiative? It's a toolkit, so it's a guidance document, but it's a guidance document that definitely goes beyond ink on paper. It's something that is from the very start meant to implement, to create action. And it does so in two ways. The first one, it identifies and lists ambitious action, things that we all know we should be doing more, but for one reason or another, we are not yet doing. So we have used the collections from the WHO best buys. We have used the collections from the joint actions and collaborative activities that the Commission has financed in the past. We have used research material from our colleagues in DG Research. We have used results from the OECD. All of these we have collected. We have collected also suggestions from the member states, suggestions from the stakeholders, and it's a reminder. These are all the things that we should be doing, and the member states can use it as a shopping list at identifying what is making more sense in their particular context and case. Importantly, we are also giving scope and promoting and inspiring, we hope, the member states to test ambitious, innovative ideas. So it may not have been completely evaluated yet, but if it is promising and if the member states think it has a population-wide effect and the potential for system reform, we are very keen to support their work in these areas as well. And as I've mentioned, especially on prevention and promotion, because that's where traditionally the underinvestment has been. The other leg, the other pillar of this work is the identification side by side with the action that we should be taking of the legal and financial tools that can and should be used to bring these ideas into reality. We would like to have the member states having a full plan to use the entirety of the European budget, not just the EU for Health program that traditionally is used for health, but the remainder as well. Or should I say the bulk of it as well. And this is because we know from experience that most member states are aware of most of the tools. This is to be expected, of course, but we are also keenly aware that many of them don't know about all the possibilities. So in the document, you will also find examples of how some countries have already been using, for instance, the European research budget to promote health. This is probably not such a big surprise, but also other tools that have been grown in importance in the past, such as those that are specifically aiming at reforms, or other legal tools or framework policy tools that are very relevant but are still underused, like the European Child Guarantee, that can also be helpful, for instance, to frame the marketing of certain types of foods, which is an important risk factor in terms of diet. Importantly, we have been putting our money where our mouth is, and I'm talking to you from the Commission, but in particular from DG Santé. So you will find already that in our own program of EU for Health, that the Parliament has been kindly helping to reinforce in the negotiations. Just a little while ago, it seems a little while ago, we will find that there is a major reinforcement of the work in this area. 100 million euros plus has been placed for work of the member states and of the stakeholders side by side to address initially the areas of health determinants, cardiovascular and diabetes. And we hope that in the near future, the other strands of the initiative will also be covered. One very, very important point from our side to mention specifically here when we are discussing with the Parliament, when we are discussing with the stakeholders, is to say that this was, we think, an innovative process and an ambitious process, both in terms of content, as I've tried to describe, but also in terms of the way it has been brought to life. We have been co-drafting the document and the way to move ahead with the member states, and also with the stakeholders in this 6 months window between December and June 22, which is our objective to have the mature document. It has really been a process of engaging every couple of weeks, either with the countries or the stakeholders. So it's not just a one-shot public consultation. It's been really a process of working together on the same document and changing the sentences together. And we think this has been very productive, and I hope you will agree, also something that we may wish to use as an example in the future. And we are quite confident that the document is much better because of the initiative, the document, and the fact that it has now many more financial opportunities to be taking us into implementation stage. Just a couple of final words to tell you about the calendar. As I've mentioned, all this work has started on 15th of December, and our idea is now to have presented the initiative on the 22nd of June in presence of our commissioner, and we hope also of members of the European Parliament and surely of stakeholders and member states. In a nutshell, we believe that this is quite relevant when we are now discussing cardiovascular and diabetes, because of the fact that this is likely the first time that we are targeting in an ambitious and comprehensive way the main sources of mortality and morbidity in the EU, complementing the European Cancer Plan. It's also something very practical. It's a guidance kit that includes the actions that countries are prioritizing, but also side by side, the way to do it, the means, the tools, legal and financial, that may be helpful, starting already in 22, not in 23 or 24, but already in the work program, in the case of the EU for Health program, already in 22. And as I've also mentioned, I think this has been a more qualitative process with more quality because of the way it has been done. This participatory co-creation process that has involved many other services of the Commission, but also the WHO, the OECD, the European Investment Bank, and very clearly and very at the central stage, the member states and the stakeholders. This to me seems very obviously very important for diabetes. As I've mentioned, this is one of the strengths of the initiative. We are very proud that ambitious and interesting ideas have come up and the member states are prioritizing them. It's not yet finalized, so I don't want to reveal too much, but can mention that there's a lot on prevention, but there's a lot also on screening. And we can only hope that debates such as the one that we are having today will make this even more important, both on diabetes and cardiovascular, and that the member states will make full use of this opportunity. Thank you very much. And I'm, of course, more than happy and to welcome your questions and to try to reply to them. Thank you.
Thank you so much, Mr. Furtado. We will see you back later for the panel discussion, but I want to thank you for presenting, and you said it yourself, an ambitious initiative, but very much a realistic and practical one. So thank you for that. And we look forward to seeing you later. Now, our next speaker is Professor João Felipe Raposo. Professor Raposo is the clinical director of APDP, the Portuguese Diabetes Association, and also the president of the Portuguese Society for Diabetology. He's an assistant professor of public health at the Nova Medical School of Nova University in Lisbon. And Professor Raposo, you will be speaking about how we can improve diabetes care and quality of life. And you said the other day when we spoke, you said that a high quality diabetes care is a mark of the quality of the health system overall. So I look forward to hearing you hopefully speak more on that and to share the priorities of the diabetes community. And because I know you're such an efficient person, Professor Raposo, I know you'll give us your 8 minutes very effectively. So thank you.
Good morning to you all. Greetings from Lisbon, Portugal. And first, let me start to greet also the European Parliament and the members of the European Parliament, but also the IDF, and thank them for the opportunity to be here presenting my point of view. And I think you'll be, at the end, I think most of you will share the same perspective. So again, let me try to share it. And I'll try to do in a different way, just to put my, okay. So we'll have my image and I think you are seeing quite all right. So I'll move for the next slide. So again, this is something that you all know, but as Mr. Arthur Furtado said, sometimes we should speak about the numbers, but the most important thing I want you to look at, it's the image of Europe, and you can see how heterogeneous is Europe just concerning the prevalence of diabetes. And that means that also we have that problem in Europe, while we are a huge region with largely heterogeneous results, either in the prevalence of diabetes, meaning that we are failing in the prevention, but also in the diabetes outcomes, health outcomes, meaning that the process of care are not really homogeneous all around Europe. Access to care is different, access to technology is different, meaning that the cost of diabetes is increasing in most of our countries, and we have difficulties to control, and we have difficulties to achieve the best results for our population. If on the top of that, you know that 1 in 3 people with diabetes is still not diagnosed, if we know that diabetes still reduces the life expectancy by up to 10 years, I think we don't need anything more to convince you that diabetes really represents a problem, and we have to do something. And while it's very important to have that focus on prevention, because it's also about our quality of life, it's about the quality of our society as a whole, we must discuss the full length of our intervention from the primary prevention to the last moments of our intervention in the healthcare process. And as that, we have just been presented by these 5 priorities around the disease journey and the quality of life and inequalities. As you can see, diabetes fits quite well in this process, either in the primary prevention of type 2 diabetes, and we should never forget also that we are not forgetting type 1 diabetes, but we still don't have resources to do effective primary prevention in type 1 diabetes, but it's still something, it's an unmet need in our region, in the world. So it's about the National Diabetes Plan. It's about registries and observatories. It's about how to target people at risk, how to identify population at risk. And it's that last box in the bottom about raising awareness, and awareness is never too much. but tackling stigma and discrimination, it's quite important. It's still part of the life of people living with diabetes in our region. And then when speaking about the screening and early detection and early action, it's again talking about data analysis, but it's also about reporting, analyzing, and taking actions from the start again. And again, most of the countries in Europe don't have national type 2 diabetes screening programs. And it's depending on the countries, but most of the times we need a strengthening of our primary care system. But as I told you in the beginning, it's just not about primary prevention. We have still huge needs in secondary and tertiary prevention. So we need to have the tools available to all to ensure early optimal glycemic control. And we know that we have to do much more, but really much more, to involve people living with diabetes, either in the process of care, taking care of themselves to achieve the best results, the best outcomes, and the best perspectives of their life, but also to involve people living with diabetes in the decision process, in the governance of the health system. And we have to do much more also to improve the quality of life. And we have to move from just saying that we have all a patient-centered and a value-based system of care and actually move on that direction, but we don't have that. And of course, and I showed that in the beginning, one of our targets is also to reduce inequalities in health outcomes, because our reality in Europe, it's not good on that process. So and I'll have to move forward in this presentation, but just primary prevention of type 2 diabetes, it's again, speaking about the national diabetes plans, it's about the national diabetes observatories. We have to have good data in Europe, and we have to have the same outputs to be analyzed and to be compared and to do effective benchmarking in Europe. And the point of awareness and the stigma and discrimination, it's quite important. The data and the cost-effective screening programs. And we must know that it's not just trying to diagnose those 1 out of 3 that are undiagnosed in Europe, but it's again to put those people in the health system, to take the best care of them in the early phases, because we know that's the effective process of care, saving a lot of money in our health systems. And I'll just move for this last part here about the patient-centered care models, because again, if we are just speaking about primary prevention, and that's, again, it's a very important point, but it's not enough to have the best results. We are spending a lot of money in the last part of the process, and we are not really involving the patients living with diabetes in the process of care. And so it's about also to have access to health technology, and it's about developing those measures that we are not using in Europe, the PREMs and the PROMs, so the patient-related outcome measures, the patient-reported experience measurements, because the first results, the first pilot results, and we have been just presented, we in Europe have a lot of pilot projects in course. We have a lot of good experience, but we are always on that phase. We have not a unique intervention, even if it's good or not. We are not doing that at the European level. We cannot compare our results all around Europe. And that's certainly one of the problems that we have here. Again, and as that, we have those inequalities in health outcomes, and we are still doing a poor job addressing the socioeconomic determinants. Diabetes is much more than just a health condition. It's a result of our system, of our societies as a whole. So it's about food, it's about physical activity, it's about work conditions, it's about interventions at school, it's about how do we take care of the elderly population, it's about the healthcare system. So it's one of the global diseases. And as Kasia has mentioned at the start, and I was speaking to her, diabetes can be seen just not one more disease, but as a marker of the quality of the health system and well-being societies. And so we can have, if we want to promote good results on diabetes, we must be sure that if we achieve that, for sure our health system would be much more resilient, our society would be much more resilient, and we would have a society, healthier society. And when Mr. Artur Furtado was speaking about the health system, this is not just about the health system, as we all know, it's about the global economy, it's about sustainability, but it's also about thinking about ambition. And it was good also to hear that word on ambitions. It's about integration, not only in health, but it's again, those health in all policies. And we must see diabetes as a global challenge. And as that, I think I'll did my best to keep the 8 minutes, Kasia. And I thank you so much for your attention. Thank you.
Thank you so much, Professor Raposo. And sorry for stealing your ending quote there. I just thought it was so excellent. I wanted to reference it.
No, my pleasure.
Thank you for sharing this. I think this definitely sticks with me. And there's one thing in particular that I find quite staggering, and that's what you had in one of your slides about 75% of the expenditure on diabetes is due to preventable complications. That to me is really a staggering figure that we have to do something about. Thank you so much for setting the stage for our next speaker, Professor Martin Halle. Professor Halle is the president of the European Association for Preventative Cardiology, and he's also a professor at the Technical University in Munich in Germany, where he leads the Department of Prevention and Sports Medicine at the University Hospital. Now, Professor Halle, as a cardiologist and sports medicine specialist by training, I understand that you're very interested in both primary and secondary prevention of CVD, as well as sports cardiology. And you'll cover the CVD perspective today and speak about how to improve CVD care and of course, quality of life. And you mentioned the other day, you said that, you know, in terms of prevention of cardiovascular disease and diabetes, you said by preventing type 2 diabetes, we're preventing CVD. So again, I hope I'm not stealing your ending quote, but I found that so interesting, and I hope you'll share more about that in addition to sharing the priorities of the CVD community. So please take the stage.
Kaiser, thank you for the introduction, this nice introduction, and I would like to welcome everybody here and start off here. So it's a great pleasure to be here. As a cardiologist, you would probably expect that I talk about how to improve stenting and all these issues that we do on a daily basis. Let me start off again here and make clear that metabolic disease and diabetes is the driving force. It is not only involving here, as you can see to the left, the coronary artery or any other arteries in the body, brain, the eye and kidney and so forth, but it's primarily also the microcirculation that leads then to heart disease like heart failure or atrial fibrillation. So this is the 75% that Kaiser was talking about. Let me focus here a little bit on this, and we have heard this already, primary prevention, very important. And here is the diabetic patient with the heart disease. And yes, we are very good at high-tech procedures, pharmacological therapy, driven also by pharmacological companies. There's the money. But the cardiology training also is good, in diabetology training. Yes, we have established that in quality of hospital care, super duper. But what we are not really good at is that we look at lifestyle intervention and really looking scientifically in that. And the scientific approach here is that we definitely need risk prediction models to be improved. We need definitely RCTs in lifestyle intervention. If you know that only in preventing diabetes, we have 3 large trials worldwide that have assessed lifestyle intervention, maybe smaller I'll come to in a minute. So it is, and we have hundreds and hundreds and thousands of pharmacological intervention trials. This is where the money should go. Structured, broad healthcare education, this is what we need in population-wide prevention initiatives. And what we are not really good at is the same, looking at the patient with diabetes and the patient with heart disease. RCTs, practically non-existing. So I think this is where we have to address all our efforts or global efforts in diabetes, in cardiology, and also NCD prevention. Because this is what we know, top medication, this is what we don't know. We perceive that exercise is good, we perceive that nutrition is important, but we do not have the data in the extent as we have with other data. And have a look at this, physical activity, CVD risk. These are the lines here. This is from 0 activity to 500. This is reducing then with clinical coronary heart disease in red. And these are the high risk and the low risk individuals. Who are the ones to benefit? These are the ones with the high risk, with diabetes, with the coronary heart disease already established. And it is from 0 to 500. That is 15 minutes a day, reduces it. And here about running or whatever, this is not, or jogging, this is not what reduces cardiovascular risk, not what reduces diabetic risk. Look at here, weight loss over 12 months in general practices in the UK. And this is proportionally achieving remission of diabetes. I'm talking about remission. And this is if patients lose more than 15 kilograms, remission is 86%. So we have to address this. How can we persuade our patients? Can we teach our patients? How we teach our doctors? How we teach our community? If you look at weight loss in atrial fibrillation, I talked on this. This is the major component for stroke. This is the major component we have spending money in electrophysiology. Losing more than 10% weight, this is after 5 years, the recurrence rate of atrial fibrillation is 10%. If patients do not lose weight, it is 60%. Look at this, total freedom, this is physical activity. These are the ones who are not physically active over 5 years. These are the ones being active. So reduction of atrial fibrillation by just being very mildly active is 35%. When we look at mortality on physical activity, it is just 2 hours of brisk walking. This is about here, 2 hours of brisk walking per week for cardiovascular and all other NCDs is reducing mortality by 50%. So coming back to this here, so we are good at this. We are not good at this here. We need money on this, on risk prediction, RCTs and primary prevention. We also need the money for multidisciplinary approach between diabetologists, cardiologists, nurses, patient-centered therapy. We need those proof of concepts. There, I mean, not only in like exercise is working. No, what kind of multidisciplinary approach works versus usual care? And yes, large data acquisition and combining pharmacology and lifestyle intervention. This is the new score too. So we need new scores, and we need new ideas on secondary prevention trials. Look at this trial. Looking at large numbers, 1,200 individuals, RCT during hemodialysis. So this is hemodialysis, and patients are randomized to intervention during hemodialysis and controls. Large setting, 30% or 40% here are diabetes patients with diabetic nephropathy. So we have to go different ways. Also, then incorporating augmented intelligence, looking at constantly testing of blood samples in new ways, in prediction of genomics, AI to be included, data monitoring of patients, not only on diabetes, but heart rate, activity, and so forth, for a healthy but also happy population. So steps could be to optimize diabetes and CVD and NCDs is individuals at high risk identification. Yes, we need this. Genetics, imaging, novel algorithms, AI. We need new therapy aside from pharmacology. So we need non-pharmacological intervention trials, and RCT is also an education, not just say education is fine and good. No, do RCTs here as well, and data and intervention networks on diabetes, heart, and other NCDs, so work together. And we from ESC think that in this perspective, Europe, we should focus eliminating heart disease, and we think it is possible if we tackle diabetes as a driving force, if we tackle prevention, if we tackle this, then also in treating diabetic and CVD patients. But we need more research on network initiatives. The one prevention population strategy for all NCDs. We need to harmonize education strategy for preventive cardiology in NCDs. We need population education knowledge strategies, early detection of CVD, early lifelong interventional prevention, imaging initiative, CVD data sharing and digital initiative like data science centers and CVD knowledge within the EU, harmonize this among the EU, better living with CVD and diabetes and healthy heart city and healthy city. So thank you very much. Eliminating diabetes will eliminate heart disease within the next 30 years. Hope I made my point, and thank you very much for your attention.
Thank you so much, Professor Halle. Thank you. And thank you to all the previous presenters for sharing your important perspectives. We've come to something that I'm looking forward to a lot, namely a brief panel discussion. So we've since we started a bit late due to technical difficulties, we'll try to be efficient, but I know all of us are, so I'm not worried. We're going to start by welcoming back our previous speaker, Mr. Furtado, Deputy Head of Unit at DG Santé at the Commission. And then I also want to welcome Dr. Charmaine Griffiths. Dr. Charmaine is a trained scientist and is the president of the European Heart Network and chief executive at the British Heart Foundation. And Dr. Griffiths, you told me the other day, do you also have lived experience of CVD from having people close to you that are or have been affected by CVD? So welcome. And welcome also to Professor Chantal Mathieu, who's the chair of the the European Diabetes Forum. Apologies. Professor Mathieu, you're also the professor of medicine at, and this is a difficult word for me to pronounce, Catholic
University of Leuven.
Yes, exactly, in Belgium. And you're the chair of endocrinology at the University Hospital in Leuven as well. And Dr. Niti Paul, a good friend and colleague of mine. She's the chair of IDF Europe for the current period of 2020 to 22, and you're also a senior clinician. And your original engagement, if you don't mind me saying, Dr. Paul, stems from having a son diagnosed with type 1. So you also do very much have the lived experience. And welcome also to someone I mentioned earlier in the webinar, Sirpa Pietikäinen, who's the co-chair of the MMD group in the European Parliament. Ms. Pietikäinen has since 2008 been a Finnish member of the European Parliament, and you represent the European People's Party. Ms. Pietikäinen is a member of the Economic and Monetary Affairs Committee and the Women's Right and Gender Equality Committee. And you're also a substitute in the Environment and Public Health Committee. So welcome, everyone. And if I could please have you just keep your mics on and make interventions when you feel like it. I look forward to this. We have heard about the priorities from both the diabetes and the CVD community, as well as the Commission's update on the NCD initiative. I want to start by asking, we've heard a lot about the commonalities, and we could also connect the synergies that exist between the diabetes and the CVD world. But I want to start by asking, and maybe Charmaine, you can start, what are the key priorities then in contrast that need to be considered separately, and why?
Oh, good question, Kaja, and privileged to join everybody on the call today, and my thanks to speakers who so convincingly, I think, showed the synergy between diabetes and the connection between our cardiovascular disease and the importance of getting our plans and strategies joined up. I think Sirpa, you might be not on mute, but go for it. Just on difference, I guess one of the things I've been reflecting on whilst listening to the speakers so carefully this morning is that importance in getting the balance right between specific care. We know there are some very specific requirements for people with diabetes versus cardiovascular disease. But I think more importantly and resoundingly this morning, we've heard the importance of joining up our approach, knowing how diabetes is a risk factor for cardiovascular disease, and just thinking about people in a much more joined up way. And I'm really delighted to hear so much consistency this morning about the approach being taken across member states, because it's just never been more needed. I think COVID has shown us how important connections are and joined up and strategic thinking is. I think we have a moment in time to do that. And it really scares me that of the 32 million people living today, right now, with diabetes across Europe, that roughly 1/3 or more of those are undiagnosed. So when I'm looking at Martin's beautiful slides and thinking about what we know and what we don't know, I'm just really feeling today the urgency for us to have a really joined up and unified approach. And as a European Heart Network, we fully support that kind of cohesion. The one thing I'd like to call out, Kaja, that just in case I don't get a moment to say it before, is we'd also, as an EHN, really advocate starting young. So we're really worried about kind of getting to this problem right and getting to the problem right for children. So we're really interested in things like legislation around sugar for children, whether it be front of pack nutrition or marketing, and taking the best of practice from across member states around things we know work, whether that be legislative or education. And Arta's brilliant presentation laid out some of the building blocks for that. I think there was a moment for us to seize as a European community to get some, to make some real change for the people at risk right now.
Thank you so much, Dr. Griffiths. And I think your ending point as well about starting young very much connects to type 2 diabetes as well. And so I'll segue to Dr. Paul Niti. Would you share from the diabetes perspective what priorities you think need to be considered separately in an initiative like this, and also why?
Sure. Good question, Kaisa, and thanks to the previous speakers for doing such a great job of this. You always represent us well, and thank you to the CVD community for being here today. I'm also a primary care doctor, possibly the only one here in amongst all the professors and the academics. So two perspectives from me. One is the patient at the center of all of this. And I know, Chantal, with you and UDF, we've had a chat around integrated care, and integration can mean many things to many people. But for us in IDF Europe, it means integration around the patient. It doesn't mean integration of healthcare systems. It doesn't mean integration of what you're doing in your clinics. This means integration of what around the patient. So the big thing for us is holding the patient at the center of all of this, collecting the data that Zhao talked about on PROMs and PREMs, making sure that that gets integrated into clinical effectiveness, patient safety, all of the things that we are concerned about, but that's with the patient at the center of all of this. And the integration has to happen with the patient at the center of this. And Sirpa and Christel very kindly have kind of led this initiative for us in terms of holding the citizen, the community, the patient at the center of this. That's the one thing that we emphasize. Two, from a diabetes perspective, we know that diabetes drives quite a lot of the cardiovascular outcomes that you're going to be seeing. But what we hear is, what kills you. So, all the data that you see is so much mortality with cardiovascular disease, so much mortality with the others. These are complications. And what we don't see is the condition that actually drives some of this. And that doesn't come out in the stats. It doesn't come out in the statistics. And often then we lose focus on the condition that actually drives some of these changes that we see. I work for an insurer, by the way, so I understand, and I work for public payers as well in my day job. So when I look at it and I look at claims data, for instance, or I look at data that comes into health systems that doesn't accurately reflect what we're talking about. So from the diabetes community perspective, we very much like to hold that at the center of this. We want people to understand what drives this, and lots of studies that, and you raised that, Martin. I think Arta talked about this as well. And then finally, of course, from a IDF Europe perspective, I think it's about time we implemented some of the stuff that we talked about, both primary prevention, secondary prevention, and all the stuff around guidelines that we keep talking about. There are guidelines that come out of our ears. We need to be supportive. There's no point telling our patients, I told you so, when it's too late. It's no point saying to people, here's your 5 things you've got to do, and go away and do them. This is about being supportive to our communities, being supportive, co-producing with our patients, our communities, not telling them what to do. The patriarchal way of doing things has to go. We have to figure out a way of standing alongside of our patients and communities, and figuring out, some of the digital therapeutics that's around. And Kaisa, you have that. My son has a looped pump, which he had to loop himself because people weren't helping them loop it. But there's an open APS community very active in Europe and across the world. Is how we support with digital technologies, leaving no one behind, this implementation of guidelines, and also helping the professionals, people like me, the primary care doctors who don't just see diabetes, they see everything, is how you support us to actually make those guidelines implement. There's no point trying to teach me just diabetes, because there is lots of other things to teach me. But how do you support that? How does electronic medical records, how does digital intervention support both the professional and the patient to get there? So those would be the things that we would really like to focus on. Thank you, Niti.
I saw that Ms. Pietikäinen gave 2 thumbs up when you talked about moving away from traditional patriarchal setup. So I think we have a good segue later. First, before that, I want to just ask for your perspective, Professor Mathieu, from the healthcare professional perspective and the healthcare system perspective. Do you agree with the 2 previous speakers? And the same question to you. I mean, what are the priorities that you think need to be considered separately, and why?
Yeah, I'm looking at time, and so I want to use my minute wisely to really give the bottom line message to Mr. Furtado. I think it's obvious that cardiovascular and diabetes have many commonalities that you can low-hanging fruit easily approach. It's all about information, communication, screening, prevention. But we need to be careful not to make it in our eyes easy and just say, move and eat less and all will be cured. That's not what it's all about. I mean, we need to avoid stigma. Diabetes is a disease. Obesity is a disease. And cardiovascular disease is a disease. And it's not all about lifestyle. It's about genetic risk. It's about a disease. And so we shouldn't have the feeling that if we tell people just lose 10% of weight, everything will be solved. If it was so easy, it would have been done before. So we need to support our healthcare systems to help people to lose the weight and to help people to move and to exercise. And second, what Joao really illustrated also is that beside the generic approaches that also will help pulmonary diseases and mental health, etc., namely, generic approaches promoting integrated care, etc., we also need disease-specific approaches. And cardiovascular disease, yes, it's stroke and it's myocardial infarction, but it's also other cardiovascular diseases, just like diabetes. In diabetes, we have the complications like were mentioned, cardiovascular nephropathy, etc. But we also have the day-to-day burden. And so what Niti already alluded to, access to technology, for instance, to apps, to sensors, etc., for people living with the disease is essential. And if I may, let's not forget people with type 1 diabetes, the children, the adolescents, the people in their working life, day-to-day living this disease. And so, for instance, opening up the discussion on screening for type 1 diabetes to avoid any child dying from diabetic ketoacidosis in Europe. We should have that as a very important target. So bottom line for me, commonalities galore. Let's really address them. Indeed, as Martin said, let's tackle diabetes and we will tackle cardiovascular disease by doing that, but also disease-specific interventions will be needed on top.
Thank you for putting that so elegantly. I know that we're 1 minute before we're supposed to end, but I do think that what we have now, I've been waiting for this. I know you've been waiting for the perspective of the policymaker. So I hope for your patience and your another 5-10 minutes of your time. Ms. Pietikäinen, please share from your perspective as a European policymaker. What's your view on this? I guess a very general question. What's your view on tackling these two major non-communicable diseases?
Well, thank you. Thank you for the excellent event and briefings, of course, for the diabetes, but as well as the heart group that with Schaldemose, we share the membership of that group too. Well, my first pickup here is that I don't know what we should call it. Is it the metabolic disorder or what? But we should try to sort of have a broader concept on working together. And we know that there are other diseases like memory disabling diseases and others that are affected by the same and the diabetes. Then I like this general approach and specific focus as well. Then in general level, this we know it is basically with all the diseases, prevent, screen, diagnose, treat effectively, rehabilitation, and then add the science on what we know. But then when we go to this kind of a disease, what sort of bothers me, and I would like to have the Commission's comment or your comment how to deal with that, is exactly what we talked about. And this is sort of this kind of a voluntarism that, okay, eat well, exercise more, sleep well, do this and that. And then when you go next time to your doctor, it's, well, why haven't you, bad girl, done all that I advise you to do? And then if we look at our societies, I'm just picking myself who should lose couple of pounds. And then when I go to meetings with, coffee and all this sweet stuff, try to decline. You do not have time to eat. And then when you go to a lunch, it's heavy, whatever, because it's provided by the hosts, the dinner's the same. So if everything in our society sort of encourages me to sit and provides me every day food that is delicious, but not good for my health, it certainly doesn't help. And then now the question is that how can we get the workplaces to really effectively have the pauses, breaks, walking or whatever you need to have the exercise and the time for that? How and when can we tackle this extremely delicate issue of food regulation in the EU? How much sugars can you feed in ketchups and salad sauces and morning cereals and the stuff? And how much, what kind of sugars and all that? So could we there, with a regulation or this kind of a collective agreement by industry, agriculture, member states, doctors to agree sort of to change the things that you are selling firstly, and then of course, because you can't focus to everybody, I think that I should manage myself without that kind of a mentoring. But we have a lot of people who need the mentoring, and especially those in vulnerable situations. So how do we put this in school food, nurseries, on the very beginning? So these are my sort of first pickups, and then a couple of others later when we continue working together.
Thank you so much, and thanks for highlighting the societal aspect of this and the systemic aspect of this. I think that's hugely important. and especially important to tie back to what Professor Mathieu was saying, to lessen also the guilt and the shame and the stigma that's associated with both diabetes and CVD. So thank you for that. And I can say at least one positive thing about having a digital webinar is that there are no cookies outside of the room that you can be tempted by. So at least that's an upside. I want to segue into to Mr. Furtado and the Commission perspective for your final thoughts. But just before I do that, do you have any recommendations, Ms. Pietikäinen? Do you have any recommendations for the Commission on this?
Well, my recommendation would be that maybe we could have a platform to think about it and really sort of go in depth on the prevention and the first primary prevention, and there with the support of the Parliament and others to tackle this regulatory side also and go a bit outside the box in work life, family life balance in the area of food nutritional value recommendations and all that. And I can ensure that you have all of our group's support if you can do it.
Thank you so much for that. Now, Mr. Furtado, some final thoughts for you, not only on what Ms. Pietikäinen just shared, but I think your key takeaways from this discussion today. You're on mute still.
Thank you. I was saying that your kind request is even more ambitious than our initiative. I could not dream of making the summary, but I will try to address very quickly, telegraphically, a few points. First of all, to mention that you will find this in the initiative if you have a moment to read it. You will find that we are tackling and we are suggesting to the member states and providing the means for the member states to address awareness, stigma, of course, prevention, but also management, integrated pathways, digital tools, self-management of patients, integrated pathways, screening. We are trying very much that all these dimensions are actually used more by the member states, that all the tools are used more by the member states. I did focus a bit on prevention because traditionally this has been the area that has been more underfunded. But even here, I'll just take 1 second to mention that I also agree with most of the speakers that made an extremely important point against which we have been fighting, I would say, all my professional life, that most of what we call individual choice and individual responsibility is actually so heavily framed by society, so heavily framed by commercial determinants, that it cannot be with a straight face really put on the shoulders of the individual. So even here, when we talk about lifestyle, we are in complete agreement that we have to work on the choice environment. And most of it depends, it was also mentioned by several of you, on the inequalities of society and on the commercial determinants. An important line here is that by acknowledging that the responsibility is spread out and that everybody has a lot to do, this should not dilute us. This should not dilute the responsibility and should not dilute our action. And this makes us a link with what the member of the Parliament has kindly mentioned. There are indeed some regulatory aspects that we could see more developed. I think the Farm to Fork initiative of the Commission also addresses this to a certain extent. I know, unfortunately, we cannot go into detail because it would be a wonderful discussion, but things like reformulation, changing the amount of sugar that we find in the yogurts in the supermarket, or the public procurement of food, the 80 billion of euros that are spent every year to buy food for our canteens, for our ministries, for the prisons, for the health system. This is a huge lever that we can use to both improve the offer and also create a supply. And also marketing. There are also some very interesting regulatory aspects that could be addressed. The European NCD Initiative allows the member states, and more than allows, lists this there. And we have specific best practices in this area that we are suggesting that the member states follow, improve, replicate, and we are putting the money there to do it. If I can just be honest, I mean, we cannot do much beyond this because of the legal requirements, the legal limits, but We are listing everything. We are reminding the member states. We are putting them together. We are putting the money there. And third, we've been discussing this in a way that we hope is the best assurance of engagement and use of the opportunities, which is this co-creation participatory process with stakeholders and member states. And yes, the final point, I mean, I had many other things, but a final point to say, again, complete agreement. There are too many inequalities around Europe in this area, and unfortunately others as well. Our idea is not to stick with the minimum common denominator, it's actually to raise the bar for all. This should be at all times our common objective. We have the tools to do it. We should have more of this joint work with the Parliament and with the stakeholders in order to assure that this will actually be done. And I hope the EU NCD initiative is really going to be an important tool for this to happen sooner rather than later. Thank you.
Thank you so much, Arthur. I see a lot of agreement in the chat overall of the event, and I want to highlight as well Anne Felton, who's the president of the Foundation for European Nurses and Diabetes. She mentioned that today is International Nurses Day, so a huge thank you to all nurses working in non-communicable diseases. We are very much running over time, but from my part, I want to say thank you so much for being here today. It's been a pleasure to listen to. I am so proud of, if I can say proud without sounding condescending, I'm so proud of hearing of all that's going on and to feel the both ambitious but realistic initiatives. Ms. Pietikäinen, do you want to say one last word to close off this webinar?
First of all, I would like wholeheartedly to thank all of you, and I hope that this will be this kind of a pact of cooperation that stays and that broadens step by step the actions together, both in the Parliament, in the Council, and of course with the Commission and the specialists and patients and the NGO community. Then the third point is that I hope that with the help of you all, we could create that kind of a pretty extensive program to start lobbying on, so that it could be on the program of the Commission for the next Commission. And then any these kind of points what you can share, how to make it happen, how to get gather the political support is very important. With these words, wholeheartedly thank you for all this good insight, and looking forward to seeing you on the next meeting, hopefully physical this time, and enjoy your day and have a nice weekend.